So let me introduce François Houÿez, who comes from Paris, studied at Pierre and Marie Curie University in Paris at the Faculty of Medicine, and has a long time, I think, in patient advocacy. Started out in AIDS, HIV advocacy, and since many years is the director of EURORDIS, the European Association of Rare Diseases Patient Association. And I had the pleasure 2 weeks ago or a week ago to attend one of their meetings in Barcelona. And I have to say, very well organized, and really I appreciate very much your scientific input and bringing the patient perspective on top of the agenda. Thanks, François, for joining.
Thank you, Jörg, for the introduction, and good afternoon to everyone. During that workshop, the Commission, Bela Dajka, explained the work plan for next year, and I think there are many lessons to learn from that. So, as you may have read, the plan is to assess 17 oncology products and up to 8 advanced therapies, but probably there won't be 8, maybe 4, no medical devices, and 10 scientific consultations, no more. And we won't see these reports before 2026, because they will start in January and be done in parallel to the CHMP, plus 67 days for the Commission and 1 or 2 months before these HTA reports are published. So we will have 20 reports in 2026, and already in 2027, the European Commission will evaluate the cooperation. And at the end of 27, we should have conclusions on whether we are going somewhere with this cooperation, or if major changes are needed, if, for example, it has to evolve in a European HTA agency or any other changes. So in fact, I think everything will go much faster than we anticipate, than we think. And this is a reason why things have to be done right from the beginning. We won't have the time to make small changes, to evolve the implementing acts, etc. These HTA reports and GCAs will have to work from the very beginning, and this is what we need to assess. So we hope this cooperation will increase the transparency. We hope it will increase the engagement of patients both at European and national level, and we are confident. We see some HTA bodies who never worked with patients in the past, who are now calling meetings with patient organizations to discuss how to work, and that's a good sign. We hope that the clinical element, the European reports, will be made available faster, so at least member states will have the clinical elements earlier than in the past, and they will be published shortly after the marketing authorization. We will see during 2026 how member states use this European report. We will have 1 year to assess that. And from there, our expectation is that from the moment national HTA bodies will use this European report, they should be in a position to respect the 180 days legal delay to decide on reimbursement and pricing. Until now, many did not respect this deadline because they said we don't have the information we need. With the European report, they will have exhaustively all the information they need on the clinical elements, and then they can focus on appraisal and reimbursement decision and pricing. So we hope that they will respect the 180 days delay. But for this, there are clear needs to increase the resources among HTA bodies. We know they are overwhelmed with many assessments, many procedures at the national level. They don't have enough time to think how to change and adapt their national working procedures to take into consideration the European report, or to follow the training when new methods are being proposed, developed by academics, because of these overwhelming numbers of assessments they need to do. So it's really a call for all HTA bodies to revise their processes to integrate this GCA report. This is a comparison we made at the EMA, the learning curve when new member states joined the European Union. We compare 2008 and 2016, and we saw a progressive shift, a progressive change in which countries served as rapporteur or co-rapporteur at the CHMP. So initially, most of the work was done by 7 member states, but over the years, more member states, more national regulatory agencies learn how to become rapporteur and co-rapporteur, so the tasks were more evenly distributed. We hope to see the same in this European cooperation. We don't think it would be useful if the same HTA bodies would conduct all assessments. We need to share the workload among different HTA bodies for different HTA bodies to learn how to serve as an assessor or co-assessor. We think the number of PICOs need to be reasonable. We've seen simulations from industry, but also from UNETA, and we have some concerns about these high numbers of PICOs. You will say, well, that's not your business as a patient organization. It's the business of the developers to address all the PICOs. But we think it wouldn't be fair to request PICOs which don't make much sense, medically speaking or scientifically speaking, but only because in some member states the standard of care is such that they need to compare to this product, even if clinicians and patients know that this product should not be used anymore because there are European guidelines that indicate otherwise. So our organization, EURORDIS, thinks that a reasonable number of PICOs should be limited to 3, and if there are more PICOs in very small populations, then maybe not to request them from the beginning, but to integrate them in the data that need to be generated in further evidence generation for the update of the European report, because it takes time, more time, to collect evidence in these PICOs that we call exotic, but there are other less polite names to name them. On this, and this is an extract of the regulation, the definition of the assessment scope, and that's how it reads, means the set of parameters for joint clinical assessment in terms of patient population, intervention, comparators, and health outcomes requested jointly by member states. So question to you, how do you interpret this definition? A, do you think it says jointly means member states request one set of parameters defined together for joint clinical assessments? Or do you think it means 2 jointly? Or does it mean member states request different sets of parameters simultaneously but not together? I won't ask you to vote, but I think we all have in mind the same response. So we'll see how it goes. We'll see how the subgroup on joint clinical assessment will interpret the European, the definition in the European regulation, which is a law that has to be respected. We also think that adequate time should be given to the developer to respond to these PICOs, not because we are here to defend the interest of the developers. It's the role of industry to defend their interest, but we are very concerned, we would be very concerned if the reports, the HTA reports, would contain pages and pages and pages of the same response. The company did not submit data in response to this question, or the data submitted by the developer was of poor quality. For example, if many different indirect comparisons need to be conducted, many different analyses need to be done, and there is too little time to do a high-quality analysis, a risk could be that we end up with poor quality HTA reports simply because not enough time was given to the developer to respond to all the questions. So we propose to reverse, to give more time for the developer to respond than for the HTA to define the questions. Because if the reports are not informative, then what will European clinicians, European patients, in addition to European and national HTA bodies, think of this European cooperation? If they are not informative, if at the end of reading it, you think, okay, and so what? Where is this leading us to? And you don't see clearly an indication from this report, we may end up again with the impression that the European institutions know how to create very administrative processes with little impact and little use. So for the added value and for the evaluation on whether or not this cooperation will be a success, we need to have reports where all stakeholders find information of interest to them. We need also adequate involvement of patients and healthcare professionals in the joint clinical assessment, scoping the assessment itself and the report review. We need to test to use the conventional methods, surveys, focus groups, etc., and other methods that need to be developed. I will come to this in a minute before I conclude. We also need to make sure that this cooperation will represent a high standard in transparency. It's an abnormality that the composition of the coordination group and subgroups is secret. At the national level, all commissions, committees publish the names of their experts, of their members, not at the European level. It should be the other way. We also think that in these procedures, even when patients cannot contribute to the discussions, because not all patients will contribute to the discussions, they don't all know how different member states, what is the standard of care in different member states, but at least for them to be there to witness how things are done, how scoping is discussed, how the data are assessed, to be able to explain to their members after the procedure how this cooperation works is in itself a major progress in terms of transparency and trust between the civil society, the patients, and this cooperation. So some solutions we really advocate for: educational programs. EURORDIS has the honor of leading one of them together with EPF and the University of UCAPA. We are training patients not only in oncology and for advanced therapies, but patients to prepare them to the European cooperation and HTA, and UPATI also has HTA for patients. And we need to ensure continuity in these programs. We also want to mentor patients better. There will be people, there will be patients who have no idea what HTA is about, what a briefing document is, what scoping or an assessment report is. We'll need to accompany them, not just send them a document for them to comment on. We need really to mentor their participation in these activities. The report summary should be in all languages, and we insist on the responsibilities of patient organizations that will be involved when we agree to be part of a procedure, when we agree with the methodology, and when we are given the possibility to express ourselves. And that may be more for the national appraisal than for the European GCA itself, but at least we should accept the outcome of the HTA procedure, even when we are not satisfied. One method I'd like to finish with this, the way patients can contribute to HTA in different ways, and we are wondering why it has to be systematic for the discussion on the scope. We think it should be systematic on other aspects to define the unmet needs that we all have in our respective diseases, and nothing is foreseen about that, or sharing the horizon scans that all our organizations are doing, highlighting which technologies are a priority for patient organizations. Do they match the horizon scan of HTA bodies, the list of emerging technologies or not? And for patients and their organizations, we really need to work with academics to generate patient experience data and patient preferences studies, which is a structured way to present how a certain number of patients weight the benefits and the risks of the product. I borrowed one slide to Isabelle Ruiz from KU Leuven. Maybe you can't read it, but that's exactly what we need. This represents the future contributions of patients and their organizations to HTA report. What it says here, for which type of benefit in terms of progression-free survival would compensate for some side effects. So you see which are the side effects that really matter to the patients and how much benefit in terms of PFS gains, they would accept to compensate, for example, for severe, moderate, or mild diarrhea, or from a pill every day to an intravenous treatment for 6 months. And with this quantification of the patient preferences, that can really inform the decision makers. And with this, I thank you for your attention.